What about when they do relapse, Luigi? So say, let's take an example of a patient who's had bendamustine rituximab. You're a run-of-the-mill patient, no one you're really overly worried about, but relapses 4 years later. How do you approach that patient?
Well, if it's a young patient, I try to do as a second line. If I used BR in front line, I use CHOP R for 3-4 cycles, and then I do a consolidation with autologous marrow transplantation. I know that not only in the United States, but also in Europe, there is a reduction concerning the role of autologous marrow transplantation in terms of consolidation in follicular lymphoma. But in 2-3 patients per year, young patients, I try to use this in second line.
How about you, John?
I think it depends on the patient, of course, right? Those people that progress very rapidly, I'm going to be thinking more about getting them to a transplant. And those people that have had many years of remission, I'm going to be thinking about being very conservative with them. And I'm not a big fan of using more chemotherapy in the relapse setting. I'm not a big fan of using more bendamustine. If they had bendamustine up front, it's a very myelosuppressive agent. We see this all the time as a complication from bendamustine use of over-delivery of the agent. It is true that if you had many years of remission, it's not unreasonable, but still myelosuppression is going to be a potential big problem. So I'm more of a fan in those relapse setting in an older person being relatively conservative. It may be single agent rituximab. It may actually be a PI3 kinase inhibitor in the right patient who needs a little different therapy, and I think we're going to talk about PI3 kinase inhibitors. But that's a class of drugs that we really don't think about enough in lymphomas. In the community, it's certainly not as well thought of, and I think it's a class of drugs that we don't want to forget for the right patients with follicular lymphoma. So sometimes that's going to be a go-to option as well.
Yeah, I think you bring up a good point about maybe just some single agent rituximab. There are a lot of choices. You could alternate to a different chemotherapy. You could give rituximab. We're going to talk a little more detail in a minute about R squared, but that's another option. There are those high risk patients that Pierluigi talks about that maybe transplant is used. I think in Nebraska you're saying you're doing transplant for some patients.
It's a very select population that you had a risk-benefit discussion with, and what the intent of that consolidation transplant is. I think it's interesting as we see more bendamustine use in the upfront setting. What's the response rate to CHOP plus an antibody in second line? I don't know that there's anybody knows truly that answer, and that's a question that's being studied in a high-risk group. But I think it is, Carlo Casula had kind of early relapse auto data from a CVMTR registry that kind of showed that perhaps there was a benefit in that population to auto. We haven't gone down the allo track yet, but there may be a role. At select centers that has select data from single institutions showing, allo transplant in the multiply relapsed young fit follicular lymphoma that hasn't transformed, could lead to long-term durability, obviously for risk of transplant-related mortality, though.
Yeah, I think it's very hard to be dogmatic in that setting. The frontline selection is complicated enough, much less the second line. There's so many different options, and it's not clear to me that one's better than the next, and you have to be taking all these patient factor selections.